Hi, everybody, and welcome. I'm Jocelyn Momento with Hartford Healthcare Live in St. Vincent's Medical Center studio in Bridgeport. A special welcome to all of you joining us from the Connecticut Post Facebook page for this monthly checkup. Be sure to post your questions in the comments section so that we can answer them during this discussion. And we want to hear from you. Joining us today is Dr. Paul Berard, medical oncologist at Hartford Healthcare Cancer Institute at St. Vincent's Medical Center. He's here to talk about the coordinated, comprehensive cancer care offered here at St. Vincent's and really throughout Hartford Healthcare. Dr. Berard, what does it really mean when we talk about coordinated cancer care?
Well, cancer treatment, the different modalities that are used to treat cancer include surgery, radiation, and then the use of medications. We traditionally think of it, the medications in terms of chemotherapy, though I think over the last 20 years we're getting away from chemotherapy and using different types of what are now referred to as biologics. So increasingly, the care of an individual patient with cancer requires input from the different subspecialty areas.
Let's talk about some of those specialties. What are the specialties here at St. Vincent's?
Well, we have a number of very well-trained surgical oncologists. So these are essentially surgeons that do cancer procedures, for the most part exclusively. The radiation oncologists, and we have two phenomenal radiation oncologists here. So they, I would say on occasion, cancer is treated with radiation alone, but for the most part, it's usually a part of overall treatment. So oftentimes, say, combined with chemotherapy or combined with surgery.
It is amazing the program that we have here. What makes our program stand out from your perspective?
Well, I think, St. Vincent's is a community hospital, and so there's a large commitment, I think, to the health and well-being of the community. And so we have a number of very well-trained physicians who essentially apply state-of-the-art care, but then also personalized care and supportive care, as opposed to, say, some of the major academic centers where their primary role is to advance the state of the art in terms of treatment. So there the emphasis is more on experimental type treatment, whereas our primary focus is the well-being of the patient.
The focus is the patient.
Right.
And in the past year, I know we've expanded our staff here. And we continue to expand.
Yeah, I think Hartford, since Hartford has taken over St. Vincent's, we've made tremendous advances. And I think one of the areas where they've made advances, they've brought in a number of excellent physicians, so that most treatment options are available here.
Yes, and that is a great thing for patients who are just discovering what we are able to offer here at St. Vincent's. But the care doesn't end when the treatment is over. We also have a survivorship program. Tell us more about that.
Well, I think just to backstep a little bit,
Yes.
I trained in the late 1980s. So at that point in time, we had very few options, or much less than we have today in terms of what we could offer patients with cancer. Survival was not good, and for those that are older like myself will remember the days when cancer was referred to as the big CA, and it was analogous to a terminal disease. So in the late 1980s, we were just happy that people were alive. But I think as the treatment advances have been made, more people are being cured, people are living longer and longer. Over the last 20, 25 years, we've actually looked at what happens to people after they've been treated for cancer. So, we've looked at things that, well, what are the long-term risks in terms of potential cardiac complications? What's the effect on cognition? What are the emotional and psychological issues that people have to deal with, as well as the financial issues? So that has brought up the concept of survivorship. And more is being learned, and I think there are more options in terms of managing some of these long-term complications. So it becomes more important, and it behooves us to follow people afterwards. So we have a very active survivorship program here, which I think offers a tremendous benefit to the patients.
Absolutely, and as you said, they are monitored closely so that the transition is really done smoothly.
Yes, right. Basically, it's a handoff.
Yes.
I mean, we continue to follow people, obviously, but the survivorship program gets involved, shortly after therapy is completed.
I've heard so much from patients who've come through our Cancer Institute about that one-on-one experience with everybody in the staff, from those in the who are getting radiation, from the technicians who provide that to everybody in between, and from and up to their surgeons.
Right. I think I consider myself blessed to work at St. Vincent's because the staff, and by that I mean everyone that works here, are dedicated, committed, and care, and that makes a huge difference.
Let's talk also about November is Lung Cancer Awareness Month, as well as Stomach Cancer Awareness Month. Lung cancer more common, stomach cancer more rare, but we also received great news today that from the American Lung Association saying how Connecticut is the #1 state when it comes to survivorship, 5-year survivorship. Does that surprise you?
No, it doesn't. It doesn't. I mean, just to give you an idea of the scope of the problem, in 2021, there were approximately 235,000 new cases of lung cancer diagnosed in the United States. And it continues to be the #1 cause of cancer-related mortality, being responsible for about 25% of cancer deaths. So it's still a major public health problem. Now, on the bright side, I think with all the smoking cessation efforts, that 235,000 represents a decrease. I mean, the numbers have been decreasing over the past 4 to 5 years. I think one of the reasons that we do well in Connecticut is because of early detection. Because the earlier the stage that lung cancer is diagnosed, the better the prognosis.
Is lung cancer the most common?
It's the most common cause of cancer deaths. Okay. In women, it's the #1 cancer diagnosis. In men, second only to prostate.
You were just talking about how early detection is key to all this. So how is lung cancer detected?
Well, it's usually detected on an imaging study, oftentimes a chest x-ray that a patient's physician may request for one reason or another. Occasionally, lung cancers are missed on a chest x-ray, and CAT scans are more sensitive. We do have, and I believe one of the questions was in terms of screening for lung cancer, we have a very active lung cancer screening program here at St. Vincent's. And essentially the criteria for who's eligible for screening, patients age 50 to 80 who have a 20-pack year smoking history. So you take the number of packs you smoke per day times the number of years, and who are current smokers or who have quit in the last 15 years. So there are a large number of people that qualify for screening. St. Vincent's, I think, has made a major effort in terms of reaching out to the community so that we can capture all those people that are appropriate for screening.
Exactly, but you don't have to be a smoker, though, to be diagnosed with lung cancer. As we know, we've also seen an increase in cases among non-smokers.
Yeah, I mean, there are other risk factors for lung cancer. The first 3 are smoking. Secondhand smoke is also a risk factor. And then I think probably most relevant would be radon exposure, which when you're outside, the radon concentrations are essentially negligible. So you'll see higher concentrations in contained areas. So there, I think for most people, the area that would be risk would be the basement in their home. So radon testing is important in that regard. We also, there are some occupational exposures, in certain inhaled chemicals, arsenic, beryllium, cadmium. We do, though, also see lung cancer in patients who have no identifiable risk factors. And there, oftentimes, we pick up what's referred to as a driver mutation. So this is a specific mutation which leads to the oncogenesis and provides for the proliferative thrust of the cancer. And we actually have oral medications, and what I mentioned earlier about getting away from chemotherapy,
Yes.
that you could refer to as a biologic, which really target that specific mutation. And in those cases, the mutation-specific treatment works better than chemotherapy, or even chemotherapy with immunotherapy.
What are the symptoms that should prompt somebody to see their doctor if, for lung cancer?
The major symptoms would be a cough. Occasionally, someone may cough up blood. That's a major red flag.
Okay.
Other symptoms: wheezing, shortness of breath, chest pain, or unexplained weight loss. Those are some of the more common symptoms that people will present with.
Now let's talk about stomach cancer, which is more rare.
Right. Gastric cancer, in 2021, approximately 22,000 cases diagnosed in the United States. So a less common cancer. We see much more gastric cancer in some of the South Korea, Mongolia, Japan, China, and there it appears to largely be diet related. So that includes things like pickled vegetables, salted fish, smoked meats. In the United States, I'd say oftentimes, we see it's associated with obesity, with a stomach infection with a bacteria called H. pylori, increases the risk. We do see an inherited type of gastric cancer. There's something called diffuse gastric cancer syndrome. There, about half of the patients that have this, present with this diffuse gastric cancer, will have a specific mutation. And if one has that mutation, it increases the risk over a lifetime to about 70%.
Are there symptoms associated with stomach cancer?
The more common symptoms would be nausea, vomiting, unexplained weight loss, early satiety. Occasionally, gastric cancers will bleed and cause an iron deficiency anemia, so people may present with symptoms of anemia such as shortness of breath or fatigue.
What about treatment for stomach cancer?
Well, again, the hope is you diagnose it early.
Yes.
So gastric cancer first invades the wall of the stomach, then tends to spread to adjacent lymph nodes, and can also spread through the bloodstream to a distant site. So the earlier the gastric cancer is diagnosed, the better the prognosis. In terms of treatment options, if it's an early, very early gastric cancer, it can be treated with surgery alone. Then there's sort of a gray area in between where the person will have surgery up front, followed by chemotherapy. And the reason for giving chemotherapy there is, from past experience, we know there's an X% chance of recurrence, which essentially means that after the surgery there was residual microscopic disease, or they had micrometastatic disease. So the hope is, with the chemotherapy given after surgery, that you would eradicate any residual microscopic disease. Now, if someone presents where it has spread to the lymph nodes, in that situation, we give chemotherapy, then the person undergoes surgery, and then after the surgery, we do some additional chemotherapy.
You mentioned how early detection is key. That is key for all cancers, really, so that treatment can start sooner than later. How easy is it to diagnose stomach cancer? Is there a screening available?
There's no screening because, again, with the numbers, 22,000. Now, if you go to Japan, because here in the United States we see more colon cancer.
Yes.
Which, again, likely relates to our diet. So here we have, because of the incidence of colon cancer, we have patients undergo routine screening colonoscopies starting at age 50. In Japan, for example, they don't do routine screening, they do routine upper endoscopy looking for gastric cancer. So yeah, we usually don't screen. So I think what makes it important to be somewhat vigilant about some of these symptoms. And nausea, vomiting, very nonspecific. A lot of things can cause nausea and vomiting.
That's right.
So I would say if you have any of these symptoms, nausea, vomiting, weight loss, early satiety, and they persist, the lower the threshold you have for getting that evaluated, the better.
And we do have some questions from our viewers. I just want to remind everybody watching to be sure to put those questions into the comments section. So our first one here, Dr. Berard, you touched upon this earlier. Is there a way to screen for lung cancer?
Yes, and people that meet that criterion, again, it's age 50 to 80, with a 20-pack year smoking history, and who are either current smokers or who have quit in the last 15 years, we do what's called a low-dose, non-contrast CT scan. And that's very sensitive, and the studies have shown that saves lives.
I did want to point out to something you and I discussed as well. Because of what is now available for treatment, we're even seeing late-stage lung cancer being survived by many people, way beyond 5 years.
Yeah, and I think the two areas that have been extremely fruitful include patients, our ability to identify these driver mutations and then offer specific therapy that provides the optimal benefit.
Targeted therapy.
Targeted therapy. The other category would be immunotherapy. Now, immunotherapy are proteins that are given intravenously. They're so-called monoclonal antibodies, which interact with the immune system and sort of turn the battle of the immune system versus the cancer in favor of the immune system. So even in the case of stage 4 lung cancer, and there are various options. I would say in most cases, patients get a combination of chemotherapy with immunotherapy. And the chemotherapy is administered for, say, 4 to 6 cycles with the immunotherapy, and then the immunotherapy is continued as a single agent. Tends to be very well tolerated, and we see some incredibly durable responses.
Yeah, we're fortunate that we're living in this era where medical science is so beyond when it comes to lung cancer.
Yeah, I mean, when I think back about when I trained, I mean, this is science fiction.
Yes, fast forward.
Right.
Yes. All right, here's our next question. Does vaping increase the risk of lung cancer? Do we know enough about vaping to be able to say something definitively?
Yeah, I mean, vaping, essentially, it's an electronic nicotine release system. Does not contain tobacco. And so given that we're still early on, we don't have enough data, I think, to say one way or the other.
But it's something that needs to be looked at.
Yes.
Very good. And the next question is, do you offer clinical trials here?
We do offer clinical trials. And at the same time, I think patients are always evaluated for clinical trials, even if the clinical trials are not available here. And so, there are clinical trials offered through Hartford, which is affiliated with Memorial Sloan Kettering, and then even trials that aren't available there, we'll refer to Sloan Kettering itself, if a patient's appropriate.
Okay, so you help coordinate it and help patients find the clinical trial that could benefit them.
Right.
Very good. Thank you so much for joining us and sharing so much information. I know a lot of folks have learned a lot from you today, Dr. Berard.
All right, well, thanks for having me.
And to schedule an appointment with Dr. Berard, call the Cancer Institute here at St. Vincent's, and that number is 203-382-2475. I'll repeat that number again for you so you can grab pen and paper right now to write it down. Again, that number is 203-382-2475. And for more information about the Cancer Institute at St. Vincent's Medical Center, go to stvincents.org/cancer or harvardhealthcare.org/cancer. Thank you again, Dr. Berard.
Thank you, Jess.
And thank you all for watching. Have a great day, everybody.